So, as Neil said, hired a couple of good surgeons, including Neil and the whole group in the corner. We're proud to be part of the team that we've assembled. I think is really dedicated to care of the trauma patient here. And our latest efforts have been working with, in my role as the chairman of the state trauma advisory board, trying to improve care throughout the state for those of us who take care of trauma patients. You know, with the difference in patients who are getting treated here in Omaha and those who are coming to us from great distances who are under resuscitated and stuff like that. So that's our focus now on the state level. So if you have questions about that afterwards, I'm happy to have a conversation on what we're working on at the state level. So a couple of academic appointments. I work do a lot with the military still, even though I'm retired from the Navy. I'm still a professor at USHS, so I go out there and teach every once in a while to medical students at USHS in Bethesda. All right, so the topic is aspirin versus Lovenox, and I have to admit culpability right away. The speaker guideline indicates that we're supposed to use generic names, but as you can see here, if you break it down, and if I use low molecular weight heparin versus enoxaparin versus Lovenox, actually the number of syllables is 9 versus 5 versus 3. So I'm actually going to save you 2 to 3 minutes. So if I use the word Lovenox, so I'm all about efficiency, and that's kind of what we have. So no disclosures. So VTE following injury. The reason I took on this topic is the grand rounds. Again, this is my 5th one. About every year since I've been here for 5 years. Basically, I've been talking about things thus far that I'm familiar with and I've lectured on in the past, but this time around I was prompted to take on a topic that I'm not as familiar with. So there are some difficult things in these slides, which I'll get through, hopefully seeming informed about it, having read all these papers over and over again. But the purpose of taking on this topic is hopefully to prompt discussion. I know we have Dr. Joel. I saw her outside. I'm not sure if she's in the room or if she's listening, but the whole discussion about whether we should be using aspirin in some of our patients and we don't. I heard somebody speak on it briefly at a conference, so I'm taking it upon myself to tackle the subject, learn more about it, and create a lecture. So VTE is, as you know, PE with the blood clots in the legs, elsewhere, very common following trauma. And here's the rates. Using Google, the reference rates are very different than what I got here. I tried to find papers. There's papers going back as early as 1988. Dr. Shackford, who many of you know, published on this. DVT incidence can range from 7 to 60% if you don't give prophylaxis, and PE rates as low as 0.35 all the way up to 24%. So it's highly variable depending on how severely injured the patient is and what type of patient it is, et cetera, et cetera. So, however, DVT following trauma with prophylaxis is nominal, around 3.5. We strive to be lower than that. I think here we're a little bit lower than that, actually. I think we do a good job of analyzing we have a good process in place to avoid this. P with prophylaxis ranges again from 0.4 to 3.8. And the risk factors, as you can see for yourself, are increasing age, severity of injury, anybody who's had surgery, transfusion, femur, tibia, pelvic fractures, acetabular fractures. I didn't put that in there, and spinal cord injury. Anything that would make you immobile, less likely to get out of bed and do a lot of walking, is going to put you at higher risk. And then orthopedic trauma is, of course, is a known risk factor for VT because of the frequent need for surgery. Almost every one of them gets surgery, not all of them, of course. And then a post-op recovery period with some period of immobilization or diminished immobilization. So that's the topic. Now, for those of you not familiar with this paper, this was a New England Journal published in, I believe, 1996. And for my residency started before this, and I started my training in the late 80s. So heparin was the way to go. We did use either SEDs and nothing or heparin and nothing. And then we started using SEDs and heparin. So that's what it was when I was a resident. And then this change took place after I graduated my residency. So this is all kind of transformed as time has gone on throughout my career. But this paper, which was done in Canada, basically showed evaluated heparin versus Lovenox in trauma patients. It was randomized, double-blinded trial, ISS greater than 9, no head bleed, so they were excluded, and it was done in Canada. And what they evaluated was heparin 5,000 sub-Q Q12 versus Lovenox 30 Q12. and the outcome was DVT. And then the way they studied it was using a venogram. So I've heard about this study before, and I didn't really appreciate the nuances of it until I read it from beginning to end. But they did do venograms on it toward the tail end of their hospitalization, or sometimes earlier than that, and they used that as a basis of determining whether there was a DVT. And they found a high number of them, 44% on heparin and 31% on Lovenox, with that p-value. The difference here being the difference in proximal DVTs was slightly different, and versus superficial. Proximals are the ones that we typically treat. And the key point here is in bold, Lovenox compared to heparin risk reduction, 30% any DVT and 58% proximal DVT. So this was quickly adapted, and heparin was used, I should say, as the main means to prevent DVT prophylaxis based on this single paper. So the challenges that we face now, and all of you deal with this on rounds, is we now switch to Lovenox, of course, as a result of the paper. And Lovenox dosing is the key discussion: how early to start it, when to use it in high-risk patients such as head bleed, spinal injuries, and post-op cranies and spinal injuries. This comes up on the trauma service quite frequently, and we have discussions with our subspecialists on when to treat. The doses we use are slightly different as well. Whether to hold the medication for any surgery, we get into this with orthopedics frequently, when to hold it and when not to hold it. And then the need for therapeutic dosing verification, people that are bigger, things like that. So anti-factor 10A testing, and then the need for post-op discharge dosing and how long to treat post-discharge. Alternative use of oral agents comes up infrequently, like Eliquis, for instance. Aspirin is hardly ever discussed, and that was the reason I was prompted partly to do this review. So although it's cheaper, so this lecture is really limited to evaluating alternate oral agent aspirin versus, again, using the generic name, I apologize, Lovenox, following orthopedic trauma. And it's relevant to us as trauma surgeons here. We're not orthopedic surgeons, certainly, but it's relevant to us because we're the ones who manage the DVT prophylaxis on all of these patients, and we're the ones who write the discharge order. So therefore, we should be familiar with the topic and know what's right and what's wrong. Any questions thus far? We're heading. Okay. All right. So a little background. Medical students maybe appreciate these diagrams. You've probably seen them many times when you study for your boards and things like that. Here's the components of the coagulation cascade, illustrated in a schematic download from Google. I didn't get this from any scientific paper. Here's the primary hemostasis, secondary hemostasis. As you know, the thrombin, fibrinogen, and fibrin pathway with a platelet plug, and then a blood clot goes on, and then plasmin comes in and breaks up the clot. So you're all familiar with that after vascular injury. This one you're also familiar with, and you've probably studied this many times, and we could test in people. We're not going to for the sake of time, but intrinsic, extrinsic pathway and common pathways, which you all see. And here's where the various medications that you deal with interact. Enoxaparin, heparin are the one that you see with 10A, 2A, and into that pathway. I went into greater detail here. This is also downloaded from Google, how unfractionated heparin or low molecular weight heparin interacts with factor 10A, which is really the component that it actively inhibits, versus heparin, unfractionated. I'm sorry, I confused the word. Low molecular weight heparin versus unfractionated heparin. So the interaction with 10A and in relation to how it either activates or deactivates things and inhibits the thrombin formation. So I've summarized it here, the differences. So aspirin, as you can see, doesn't really work on the clotting cascade. It inhibits cyclooxygenase 1 and 2, whereas Lovenox primarily inhibits factor 10A, as I said, shuts down the common pathway, preventing thrombin formation and subsequent fibrin formation. It also acts on factor 2A, which is thrombin itself, and binds to antithrombin 3. The difference in doses are illustrated there. The cost is substantially different, more expensive, and I'm not even sure if this reflects our costs. I didn't have a chance to ask anybody here locally to see what our actual costs are. But There's, of course, different side effects, GI side effects with aspirin and thrombocytopenia with Lovenox. And obviously, it's intuitive to know that taking just the pill is more accessible, oral route, and it's, of course, cheaper versus Lovenox, which is considered to be burdensome theoretically, and that's its injection, and the cost is greater. So here's the studies I'll go through for the sake of this talk. Key studies, there was a lot of other studies that had to do with hip arthroplasty, knee work, things like that, which weren't relevant. These are just strictly trauma papers. I started out from the earliest to the most recent in that order. And so this is I guess it's BMJ. I always forget what that is. It's Baylor Medical Journal, I believe, or whatever it is. I can't remember. Anyway, forgotten. So patient preferences for venous thromboembolism prophylaxis after surgery. This is strictly a preference paper, and the premise being that that when you implement guidelines, and we don't often do this, when we create a guideline, we don't actually consider the actual we don't take into consideration whether the patient will be compliant with the guideline or not, which is they go into some detail in this paper about is there a reason that's coming up there? Something on the screen say Zoom workplace connecting, so you can't see the lecture. All right, so I'll look at the screen. I'm not sure why that happened. You have any idea what's going on?
Meeting is being.
Sorry.
Got it down completely.
I guess microaggressions toward technology would be appropriate here. Macroaggressions, right? Still one picture with the fist.
Just so you know, the meeting's actually connected and we can still hear the room.
Okay, good to know. Thanks.
While you're waiting for your slides to come back, I'll give you a little historical story. It was in the 1940s when heparin was first introduced, and it was the first randomized clinical trial of any condition, DVT. It's also the first trial to be stopped before it hit its endpoints because of the dramatic difference that people on heparin did so much better that they couldn't justify continuing the non-treatment arm.
That was from a paid sponsor, Dr. Shawn. There's this article on the slide.
system-wide network issues today, I'm afraid.
Can we just do it without the Zoom then? Say 50 people in the room?
Now we have to have a Zoom meeting in order to show the slides.
Oh.
Try to see if I can get free world. Yeah. No, it's not. Yeah, we can do that.
Can't fix that one. On your hotspot, Wade.
Yeah, wait.
Turn on that 5G.
I mean, even if we just keep our phone down, just
Right.
yeah, straight there.
Oh, yeah. You're gonna be there? That's supposed to be Trump, right?
Basically 40 hours. F5 next year.
Hopefully there you go. Yeah, I went
I just figured like.
Yeah.
They
Can't fix it like you do it on
You know,
purpose,
yeah,
like,
yeah.
without people seeing the slides, without like paying for it.
That's fair, yeah. What'd you say, Kayvon?
You know, those aren't like.
And
then the other little. Organization might
It was some research article for 5 pages.
Good.
I mean, that's all.
Otherwise, you know, like why, like, but.
No.
Well, that's right. He's on vacation.
Just like put it in.
Back. Okay. All right.
I have not read that paper, but I did.
All right. Thank you, guys. Good job. Okay, well, good. All right. So, okay, thanks again for your patience. So we'll go through the 4 studies that we've got, and we should be able to get through this in time. We started talking about this one. So the premise is again that guidelines should be ideally made with compliance in mind, and missed doses of regarding VTE prophylaxis, missed dose of meds are highly associated with increased VTE incidence. As you know, as we all well know from our own review of our patients here. The study goal is to evaluate preferences for ortho-trauma patients. Again, when they say ortho-trauma patients, the ones they're using throughout these studies are all pretty consistent. What they are is they're long bone fractures of the arm and the legs, and any sort of pelvic or that gets operated on, I should say, and any pelvic or acetabular fracture, whether it's operated on or not. So what they've done in this case is a discrete choice experiment based on surveys, and I highlight one of the surveys on the next slide. It was conducted in Baltimore, and all 4 of these studies were actually out of Baltimore Shock Trauma and a Johns Hopkins research group, and they seem to own this topic in terms of the literature. So in this case, they conducted it in 2017. Lovenox, when Lovenox was the only VTE prophylaxis option. This study had 232 patients with a mean ISS of 12. And for those of the students who don't know what that means, that's injury severity score, and that talks about the severity of injuries throughout the body. So here's the sample survey. It's pretty easy to figure out for yourself. very pictorial. So they basically are looking for a preference, whether it's an oral med or needle injection. They actually don't name the medication, but they're giving these graphically to illustrate. So it's very easy to understand, what your risk is, and they give numbers associated with that. It's very interesting demonstration about. They actually show 1,000 dots here, obviously with one, so that makes it very easy for anybody, even an educated person, to figure out to answer the question. So what they demonstrate here in this graph is what they call marginal utility. And what that is they're comparing throughout the survey, they're actually asking you to pick a preference. So, and that preference is verbalized as marginal utility. So when they quantified that, they looked at which was the highest priority to these patients based on the choices. What they found was that marginally, that when they make the decision is largely based on their consideration of their risk of death from PE as a primary factor in making the decision. So much so, when they reduce the risk by 1%, the individuals are willing to pay as much as $1,686.90. How they came up with that number, I have no idea, and they don't explain it, in terms of lowering your risk by 1%. And then next most important was if you're taking a medication, you had to choose between the two. The most important factor that they chose in making that decision was the risk of blood clot, of course. Less willing to invest money behind that, but nevertheless, the numbers are actually far less. So by and large, avoiding death was by far the most important factor in making the decision that the patients. And then the root was a third concern that they had. So although you would think the root would be the primary concern, it's not. It's the risk of death and the risk of getting a blood clot. And then what they show with a negative number here, as I illustrated, is that actually more of considered a aversion or a dissatisfaction with that thing. So they're happy to take the oral pill, but they're unhappy with the prospect of taking the injection. So, and then they summarize this again with another set of numbers, again showing, and you can read that for yourself, the absolute risk reduction of a potential complication that a patient would be willing to accept with the change in the preference from oral to subcutaneous route. And what that shows here is there's a very, very, very small margin that it takes to make them be willing to change that medication choice when you take into consideration of risk of death due to PE. Whereas it goes as high as 7% almost when you actually factor in if you're willing to change the medication based on an aversion to a risk of bleeding. So hopefully that's clear to everybody. Hopefully I've explained that clearly enough. And we've summarized it here so that patients value risk of death due to PE much more than the risk of VTE and other factors, and a strong patient preference for oral prophylaxis over sub-Q injection when all other relevant attributes are equal. Only a small reduction in risk of death, as I illustrated in that last slide, was needed for them due to PE to change their preference from the oral to the subcutaneous route. And again, results are relevant because patient refusal of VTE doses is a common reason for missed doses, which increases your risk of VTE. So moving on, this is that next study, the ADAPT trial, a different approach to preventing thrombosis trial. And this is where you start to get into, although I was an engineer and had some mathematic background, this is way beyond my level of understanding from the statistical point of view. So keep in mind that I try to do my best to understand it. I'll try to illustrate it to you in the best way I can by summarizing the key points. But all these subsequent papers had really very sophisticated statistical analysis, much more than you see in a typical paper that you pick up and read in a journal. So what they did is they compared the global benefit of aspirin versus Lovenox for orthopedic trauma patients within 90 days of injury. The global benefit is assessed by using the global rank index, which is a statistical factor, to determine the probability of treatment superiority amongst two or more treatment groups. And again, these are the same group of patients at 90 days, and they randomized patients to receive, again, Lovenox in a BID dosing versus aspirin in a BID dosing. And all patients were offered SCDs, whether they were them or not was not really reported. So the primary outcomes were bleeding, VT, deep surgical infections, and death. And again, since these were all the same study group, all the same issues come up within all the papers that we're going to discuss. And these are the same numbers that they evaluated in those studies. So again, a complicated intention to treat principle using this global rank index. So what they do is on the bottom, they had a previous paper that came up with these weights for these factors, which is similar to that last paper, but a different published paper, where they come actually with weighting factors. And then they multiplied that by preference data, and then they came up with this global rank index. And then they separately did another analysis called time to event evaluation. And in this group, this was 1,012 ortho trauma patients, yielded 329 enrolled because of various exclusion criteria they had. Mental status changes, things like that. Many of these patients who were more sick couldn't be theoretically on that. So there is a slight bias. If you had a very sick patient who was on a ventilator that couldn't really contribute to the discussion, therefore they were eliminated from the study. So they were randomized to aspirin and Lovenox. Here's the study group, so you can see it was mostly blunt, many open fractures. And as a result of that, taking the Lovenox or aspirin, there was many of them that were event-free. They didn't have any event in the categories that we discussed. But the global rank test showed that Lovenox had a 50.4 probability of treatment superiority. And that was below the threshold of 59% to demonstrate superiority. And likewise, Lovenox had a probability of treatment superiority which was too low based on this other statistical analysis they did, and those are confidence intervals. And again, you can see now the data is trending toward Lovenox, right? Using these sophisticated analyses. And then they move on, and this is really becomes more of the key paper, and you can see it was published in New England Journal, so it actually had a big impact. So if you get anything in the New England Journal in your career, you're pretty lucky. But this is again that same group, the same group of type of patients from orthopedic trauma, same randomization of Lovenox versus aspirin. In this case, the outcome was death at any cause at 90 days. And the secondary outcome were these same things that we discussed previously: non-fatal PE, DVT, bleeding complications at 90 days, and wound issues. I didn't mention that. But this was a more wider study rather than one center. This was 21 centers in the US and Canada, and they enrolled a much larger number of patients, so 12,211. They excluded anybody who had more than 3 doses of any VTE prophylaxis medication when they were first admitted before they were enrolled in the study. Adherence to the protocol was actually quite good, 95 and 97%. And actually 91% continued the treatment that they prescribed after discharge up to 21 days. So again, a pretty good, decent study. Here's the study group. You can see the type of patients that they had, which is a lot of lower extremity injuries. Some actually had spine, thoracic, neck, and actually they enrolled head injury patients, whereas some of the other studies didn't. So it becomes more like your typical trauma patient that we deal with. The ISS scale scores were relatively low. A majority of them had this ISS less than 9, but there were some in the higher groups. So they're not really risk stratifying based on IS. They're just looking at it globally based on any ISS and any combination of injuries is what it comes down to, is what this study shows. So bottom line is that all-cause mortality was the same essentially between the two groups, so that didn't differ. And again, aspirin was non-inferior to Lovenox with a very significant p-value, but not superior in preventing death from any cause. 86% of those who died were adherent to the protocol, so there was good study adherence. No treatment effect based on patient age for any cause. And the 90-day probability of death from PE was no different than the risk of not dying from PE. So people weren't dying from PE as a predominant factor in this study. So secondary outcomes, busy slide, but hopefully you can see some key points here. And this is something that may even come up on your boards theoretically, came up on our recent critical care recertification exam. This paper was referred to in that in this group of papers that we had to evaluate for that test. So PE again, no difference in the percent at 90 days. Slight difference in segmental versus subsegmental. And then you can see here, if I had a pointer, I would, but this number that stands out is this 2.51 for DVT. So the although aspirin did have a higher number of DVTs, and that was the test question on the test that we took for critical care, it didn't make a difference in the big picture. So proximal slightly more in aspirin versus Lovenox, and distal slightly more again, but it didn't equate to a difference in PE or death, which is the key thing. Bleeding complications, wound complications, infections are all about the same. So here's this study plot that shows the outcomes, and again, they almost pretty much line up on that zero with regard to the everything having to do with PE, and that was really the main outcome that they studied in this paper was death related to PE, et cetera, et cetera. And they looked at all different ramifications of the PE, and people. They had a committee that analyzed whether you died from a PE or a PE not contributed to death. All that was kind of outlined in the paper. Kind of a long paper, but nevertheless, bottom line is anything that they looked at regarding PE was pretty much the same. So to summarize again here, aspirin was not inferior to Lovenox for the prevention of death after long bone fracture requiring surgery or any study group pelvic or acetabular fracture at 90 days. PE rate was the same. Fewer DVTs were seen with Lovenox than with aspirin, as well as fewer distal DVTs as a side note. And there was no safety risk associated with the use of aspirin. And then this is an even more complicated paper to understand with regard to the statistical analysis. So if you're a statistics buff, I would suggest to read these two papers, and maybe you'll be in heaven. But you know, granted, suffice it to say, when you get into a really difficult statistical analysis, my brain kind of shuts down. I go, I don't really understand. If I understand this, I have to take their word. But they do a pretty decent job of trying to convince you that their statistics are sound, and it made it into, you know, in New England Journal. So I guarantee if the statistics weren't sound, it would not have gotten published there. That's kind of what my takeaway point. My career, I've sent one paper in New England Journal of Medicine, and it got rejected within a matter of 2 days. But it is generally considered the premier journal to publish for anything. So secondary analysis, and what they did is they took that same group. This was published in Journal of Trauma, and primary aim here was to determine if the treatment effects varied based on patient risk. Remember, the last one didn't really quantify that too well, didn't really look at it so closely. This one, on the other hand, did. And that's really the focus of this paper, is to see if there's any difference in any of those outcomes based on risk. And they also looked to see if the patients applied to patients specifically at the highest risk of VTE. And we'll get into that in more detail. An additional analysis was patient medication satisfaction. The way they went about doing this was with Caprini score. For those of you who aren't familiar with it, I have a slide showing you about that. To calculate the VTE risk. And again, it's that same group of patients from that last paper, the 12,221. Then this is where the statistics come in. This win ratio method was used, and they paired aspirin patients to Lovenox patients. And I'll try to explain that to you. So hopefully if somebody comes up to asking about win ratio, you'll be able to answer that question after you leave this discussion. So here's the Caprini score. It's basically, here's the highlighted things that are relevant to us as trauma surgeons. And it gives factors based on age primarily, some health factors. This is a long version of it. There's much shorter versions if you look it up. But I gave you the full detailed one. Should you want to know more about it, you can read about it, I'm sure. And then various types of surgeries, which are considered lower risk, are given 2 points. So laparoscopic surgery, for instance. Any major surgery, but you know, they don't really define the major surgeries. And then the highest risk factors give you 5 points. And that's these patients that are really studied in these various papers. And then anything with the multi-trauma, and those are what that is. And I referenced the paper, which was published, it's ISS greater than 16. This topic, although it's used now for medical patients more than surgical patients, was written in a group of surgery patients in 1991. And on the left, you can see how it's quantified: lowest, low, moderate, high, and then highest. There's a different version of which was earlier, which only has 4 categories. And I just gave you the more update one, but the one they used had the 4 categories for this paper. Anything greater than 5 to 8 points. And again, if you have multi-trauma, you're automatically in a high group, right? If you have anything, now if you undergo surgery and multi-trauma, now you're in the highest group. So it's easy to see that trauma patients are at very, very high risk of VTE. So win ratio, please bear with me. Try to read every line so you can probably appreciate it. I'm not going to do a good job of explaining it. but it's a statistical method used primarily in clinical trials to evaluate hierarchical, did I pronounce that right? Composite outcomes. And what they do is they basically pair every patient to all other patients. And then they calculate wins and losses and they take the ratio. That's kind of a very brief summary of it. I found a very good summary of it in the paper, and this is right directly out of the paper, that bolded line. Win ratio provides a single measure to estimate a difference in the totality of benefits and harms between treatments and protects against competing interests. Does that make sense? Does that make sense to you? Okay. No. Okay. All right. Well, I summarized it to make it a little easier for the paper. So they basically matched pairs of aspirin and low-molecular weight heparin patients. Pairwise comparison is done hierarchically. So they basically first compared basically one aspirin patient to all the other patients in the Lovenox group. And they did so first evaluating mortality, which they thought was, again, most important based on the previous papers, followed by the other factors, PE, DVT, then bleeding, et cetera, et cetera. So, and they calculate this win ratio of winners versus losers. So how they won was basically whether they, it statistically proved to be beneficial based on the numbers. So, and they also did a sub-analysis for each VTE risk group defined by Caprini. And here's the Caprini breakdown. So you can see there was very few in this very high category. The majority were in the 5. So these are just mostly isolated orthopedic injuries. And many of them were, but not all of them. 60% male, 40% had a concomitant injury. That raises their ISS score. Median ISS score is 9. That means you have probably not, anybody who understands that would understand that probably means you're mostly 60% of them had just isolated injuries. So that would give you an ISS score of 3. And you square that and give you the AIS score of 3. Square that and gives you an ISS score of 9. Although 14% did have very high ISS scores greater than 16, which is considered seriously injured. So they did the four quartile Caprini index evaluation, and they gave these numbers, not so much that this is important, but just to illustrate that in a high-risk group, which was 3,052 patients, the median ISS score was 16, so it was pretty high, and the majority of them had these very severe injuries, both abdominal and head injuries. So it's a valid study is what it comes down to. They do have a good group of patients to evaluate the hypothesis. So here's the analysis part. There was probably more than a dozen of these graphs. I picked out one. One was just to illustrate the statistics they did. And they basically published the win ratio for the various components of it, and the graphs as illustrated. Basically, bottom line is there's no statistical difference in hierarchical assessed outcomes with that odds ratio of 0.99, and they come up with 37 million pairs, and they exclude a certain number of them based on winners and losers. And aspirin and Lovenox won at certain things and lost at certain things. It's not so important. And then they added this satisfaction thing on the bar graph, and they found that when you add satisfaction, there was definitely aspirin again was favored, as the other previous papers would predict. And then the Caprini score win ratio analysis, basically of risk stratified groups for clinical outcomes, the two medications were statistically indistinguishable, is what it came down to. And then when med satisfaction was added, aspirin was favored in all 4 risk categories. So, and the benefit here reduced as you went higher in risk, because obviously the higher risk you go, there's decreased benefit in some of these effects, statistically speaking. So summarizing, and we're on time here, despite the technical issues, no difference in aspirin or Lovenox chemotherapy in orthotrauma patients using this win ratio analysis. So they're equivalent. Medication satisfaction uniformly favors aspirin, as we stated before. Results consistent regardless of the patient's baseline VTE risk, which is great news to me, because if I had not known about this or read this paper, I would have assumed that they use it in lower risk patients, whereas the paper would illustrate that there's no difference whether you're high risk or low risk. It holds true even in the highest risk categories of VTE. So additional support to the notion is that aspirin is not is non-inferior to Lovenox in ortho trauma patients. And as I said at the beginning of the talk, as trauma surgeons, we prescribe these medications, we manage them throughout the hospital stay. We do rely on our ortho colleagues to make recommendations, but it's up to us to know the literature and make these decisions. And then we're the ones discharging them. So ultimately, although the ortho guys have preference, it's up to us to decide what we're going to do. So having said that, the bottom line is, although we were very quick to accept the change with response to the Gertz paper and New England Journal regarding Lovenox versus heparin, seemed like it happened overnight. From what I could tell, it was almost immediate that the change took place. Everybody was using Lovenox instead of heparin. Why are we so reluctant in our ortho patients not to use aspirin and make change? Because the papers would be compelling, suggesting that we should. And that's all I have. So just like my friend and colleague who they frequently put pictures of the kids, these are not hired actors, these are actually my kids. So she was very proud. She made a car there and she's racing around the car all day. So anyway, thank you very much for your time. I'm sorry for the technical issues. Appreciate it. Anybody have any questions?
Dr. Kuncir, great presentation. I wonder, sometimes you're told something at some point in your education and you never really verify it. And then somebody raises and you wonder, well, maybe I wonder if that was not true in the first place. I remember at some point being told that deep vein thrombosis thrombi are not generally platelet rich. They're more thrombin rich and the platelets, versus like atherosclerotic plaque or something where those tend to be platelet rich thrombi. I wonder if in orthopedic injuries, due to either micro, marrow embolization or something, I wonder if in ortho trauma, those DVTs tend to be more platelet rich than, say, a surgical patient who's not an orthopedic trauma who gets a DVT. It's just curiosity. But I'm interested to see if somebody, as more studies are done, if this study, which is, non-inferiority in ortho trauma, if it's applicable to more patient populations.
I mean, I'd defer the answer to anybody here who's knowledgeable on the topic. I did read like 4 or 5 other papers leading up to these other papers, which I had to pick out in terms of which paper I would use for the sake of time. I'm glad I did because it worked out fine because the technical thing, the lecture wasn't too long, but all the papers I read didn't go into that, frankly. It's an excellent question. And the 4 or 5 papers that were build-ups to these papers that were really the foundation for these papers is what it came down to. None of them mentioned that topic specifically. So excellent question. Does anybody else think that can answer that question, perhaps? My esteemed colleague, Dr. Fernandez, who seems to be knowledgeable about everything, doesn't have, I'm shaking.
Information.
Okay. All right. Yes, sir.
Thanks, Dr. Kuncir. That was a great presentation. I'm curious, I have a couple of questions. How does this paper ultimately change how we go about treating our patients here and how you go about kind of implementing this change among the department? Are we going to be doing any changes on how we treat our isolated orthopedic trauma patients, just in general as a service? And then in the paper, I may have cheated. I was kind of reading open evidence while you were going, but they didn't assess the anti-10A levels. And I know usually at baseline for, not high-risk patients that don't have renal disease or are obese, we usually will not trend the anti-10A. But I just wonder to what level you can kind of prove that the Lovenox actually was at a therapeutic or like a prophylactic dose to say that it actually was making an impact and is not inferior.
Yeah, excellent questions again. So the papers do, there was some testing for anti-10A, but it wasn't really illustrated in the paper, like who got it and who didn't, and how many times they made changes. So that was definitely, and believe it or not, they didn't mention that in the limitations of any of the papers that were discussed. So I think that was definitely a limitation, in my opinion. It wasn't controlled, in other words. So I read through that and I go immediately, that was my thought. And the other thing is the dosing is now different. We tend to use higher doses than the 30 BID, as you all know. So there are some definite challenges in making that transition. Should we be doing this now or not? Really, my goal is, I'm glad a lot of my partners are here because I hope at some point in our surgeon meeting, we can actually discuss this topic and decide for ourselves if the papers are strong enough to be able to do this in our patients. And then at the same time, parallel to that, have a discussion with our orthopedic colleagues to see what their preference is, because although we have these papers coming through the pipeline. Very little, very infrequently, I should say, do we send people home on aspirin. We do it, but very infrequently. And I think that we have to have an educated discussion on the topic is what it comes down to in response to your question. And I see, anybody else have any opinion beyond, different than that? Dr. McCall?
Yeah, I think some of the major points to look at are that most of these patients in this study don't align with like the patient population in NTPD. So the patients were much younger, much less injured. They don't use the standard DVT prophylaxis dosing that we use. And also, I'm not sure how they calculated the Caprini scores, because if you look at the Caprini score, there's no way that a pelvic fracture can actually be a low Caprini score. So based on that, you automatically are a 5, and even based on age and anything else, that puts you in a moderate category. So I'm not really sure how they calculated those. I think the other thing is that they allowed patients to miss up to 20% of their doses of DVT prophylaxis in the hospital, which I think for us is a lot, right? So even if we miss one dose of DVT prophylaxis, that's kind of a big deal. So allowing them to miss 20% is quite a bit. The other thing is, like you said, the anti-10A monitoring and all of that we know now is better. And so you're kind of comparing apples to oranges, I think, because if you're not comparing aspirin to what we actually do and what the gold standard is, then I don't really think that's a fair comparison. That being said, I think that all applies to inpatient. Now, whether or not these patients could go home on aspirin as outpatient is a totally different discussion, but I certainly think inpatient, we haven't had a good enough study comparing what we actually do to say that we need to change our practice.
That's fair analysis. I agree with all that. All right. Well, thanks again. Appreciate it very much.